This conference will now be recorded.
Good morning. My name is Joseph Tretola. Today is Friday, October the 5th. And this morning's lesson, although I'll try to keep it under 30 minutes, is titled Medicare Basics. And it is how to decipher between original Medicare Part A and B and a Medigap Medicare Supplement plan or Medicare Advantage Part C. In other words, how will you know how to advise your clients? How will you know how to take the conversation? How will you know how to understand what they have? And we'll look at the basics. We'll look at some profiles. I've gone over a lot of this before in previous ones, so definitely a good review. So a couple disclaimers. As everyone knows, this course is not intended to replace AHIP or any specific carrier training. It is meant as a guideline only. The agent is ultimately responsible for knowing all the rules and regulations. The presenter is not affiliated with, with CMS, Medicare, Medicaid, the United States government, any state or local government, VA, SHIP, or PACE. This is not endorsed by any of the above. It is assumed you have permission to call, and it is documented as the scope of an appointment form prior to any Part C or Part D conversation for the purposes of any training. And always refer the prospect to Medicare, Social Security, or their local Department of Social Services, aka welfare, for information pertaining to financial support for healthcare. So there are typically two paths that someone can take when they're going on to Medicare. And it's a little bit easier if you understand them by paths or passages. But path number one is where they would opt to say with original Medicare, Medicare A and B. They would pick up a prescription drug plan, which is only for prescriptions, okay, RX coverage only. And then they would also purchase a Medicare Supplement, which is also known as a Medigap policy. Path number two, they opt to not go with original Medicare. They still got to pay their fee to Medicare. It still comes out of their check. But now they've decided to turn over all of their benefits, all of their Medicare benefits, everything from A to Z, over to a private insurance company. And the more common ones that you see are listed here. These are the more common ones. They tend to have a national presence. They tend to have plans in multiple counties and multiple states and so forth. It's where you turn it over to a private insurance company. Now, we're going to talk about Medicare Supplement first, and it's good that you understand who the typical Medicare Supplement buyer is, and I've gone over this before. And first and foremost, it's somebody that wants predictable health care costs. They want to start January 1st of the year, and they want to know precisely ahead of time exactly what health care is going to cost them. Exactly, to the penny. They want that predictable cost. Number two, they do not want any network restrictions. They do not want to be told where they can go. They do not want to be told what they can do. They do not want to be told what they can't do. They don't want their doctors telling them that they can't take it. They want a complete control of their health care. Number three, and I mentioned this in number two, they want to see any doctor anywhere in the U.S. or any doctor anywhere in their hometown. Okay, no network restrictions. They do not want copays. They do not want deductibles, and I asterisk the deductible. Typically, when you're coming from an under 65 environment, such as myself, being under 65, the deductibles are quite high. Our health plan has a $5,000 deductible. So somebody transitioning into Medicare, they're so used to these high deductibles, they don't want them anymore. So they'll communicate to you that they don't want a deductible. We know that with the Plan G and the Plan N, there's a very small, tiny deductible, $180. I think for next year is $185, and no cost sharing. In my plan, we pay the first $5,000, then we pay 20% after that until another $5,000 is spent for a total of $10,000. You know, that second part is the cost sharing, and we hit it this year. I had an appendix taken out in February, and sneezed, and there was $10,000, just like that. They have resources to support about $150 a month premium on top of the $134 that's being paid to Medicare. I did not adjust this for 2019. It's not that much, and it's only going up about $1. And where I came up with this 150 is I just took an average Plan G of about 100 to 125. I tacked on a Part D premium, which can average now $15 to $30, and dental, vision, and hearing, which can range from 25 to 40. Somebody who's a heavy utilizer of services, okay, somebody who comes to you that's really, really sick. I know that there's that fine line in Medicare where you cannot ask somebody about their health, and that's, the truth, but oftentimes people will reveal to you that they need a plan that's going to pay for all of their chemotherapy, or they're going to need a plan that's going to be paying for their upcoming cataract surgery, or just whatever the case is. They're going to tell you this, and you just got to make sure that when you're being cognizant about this, that somebody that's a heavy utilizer of services will benefit better in a Medicare Supplement setting than they would in a Medicare Advantage setting. And then also snowbirds and travelers, people who do not stay in the service region in their county or in their state, that are always kind of bopping around. They'll get more and better coverage out of a supplement than they will with a Medicare Advantage plan. So just kind of overview, what is a Medicare Supplement? They have different names out there. They all mean the same thing. We've heard the term Medigap, supplementary insurance, secondary plan. But at the current moment, there are 10 plans available, and they are characterized by alphabet letters A, B, C, D, F, G, K, L, M, N, and there's also a high deductible F. So it kind of falls under the F category. And the most commonly sold ones, the ones that are sold most common, are F as in Frank, G as in the color green, or N as in the woman's name Nancy, F, G, and N. They cover some or all of what Medicare doesn't cover. The client pays a monthly premium. It has to come from their bank account. It can't come out of their Social Security. They physically pay for it. They can write a check, but it has to be 3 months at a time. So it's an automatic draft. During open enrollment, which is typically turning 65, there's guaranteed acceptance 6 months before, which I don't even know why we even say that, because the policy doesn't go into effect until the day of their birthday. So really the 6 months before is just securing the rate. I don't know why they say it that way, but guarantee acceptance 6 months after their 65th birthday. So it's to the day. So it's not that their birth month is on, October 1st, and then their open enrollment will end 6 months later on the 1st, which would be April the 1st. It's their birthday's October the 13th, and their open enrollment is 6 months later, exactly 180 days later, and whatever day that falls on is when their open enrollment ends. Very important. Plan F and Plan C are being discontinued starting January 1st, 2020. Reason being is those are the only 2 of the 10 alphabet letter plans that pay for the Part B deductible. They're the only 2, so they're gone. They're out. After open enrollment, the application must be underwritten. The applicant must be underwritten unless there are certain guaranteed issue rights. And then plans of the same letter type work exactly the same no matter what insurance company sells it. This is why we sell Medicare supplements, because you do not have to compete in benefits with another agent, agency, or insurance company. They're exactly the same. So if there's a Plan G from company XYZ and there's a Plan G from company ABC, the benefits are identical. Identically the same. The only 2 differences is what the person pays for it today, and then what the person is going to be paying for it down the road based upon claims, rate increases, policyholders, and things of that nature. But as far as benefits go, they are identically the same. Here's a chart of the plans that are in current existence and exactly what it'll look like for 2019 as well. Although 2020 it will change, because of F and C is going to be eliminated. But if you take a look at the 3 most commonly chosen plans, F, G, and N, there's only one difference between an F and a G. Only one, and that is the Medicare Part B deductible. And again, these are just reflected for 2018 figures. They vary very slightly for next year. And then the Plan N, which is a bit more of an economical buy for a lot of people. And the Plan N does not pay for the Part B deductible. It does not pay for Part B excess charges in states that allow excess charges. And excess charges just means that the doctor does not take Medicare assignment. So Medicare says not a problem. We'll still pay you, but the most we're going to pay you above assignment is going to be 15%. You can go on to the Medicare website. Maybe I'll do another thing, and you can actually look up the doctor's name, and you can see next to the doctor if they take Medicare assignment or not. So if you have a client on the fence that'll say, you know what, N sounds good, but I don't want to be stuck with these 15% extra bills, who knows what that'll amount to, then you can just say, well, you know what, let's just take a look at your doctors and let's see if they take assignment. 98% of the doctors do, but it's another layer of advice. It's separating yourself from your competition. You're showing the client you care. You're using your tools. You're using what was taught to you to bring the highest quality advice to the table. Nobody's going to top your advice. That's the thing. That's what I like to teach to people. Is I'm going to teach you the best advice you could possibly give the person. And if you're ever challenged, no one will top you. You will have the best advice. So if you're going against somebody that has an existing plan G, they're not a heavy utilizer, and you're recommending a plan N, and that other agent says, well, why would you go with the plan N? You're going to have to pay the 15% excess charges. You know what? You would have already looked up the doctors. You would have already communicated to the client that none of their doctors or their hospital charges the excess charges. And when that agent tries to save that business, that client will be so educated from you that they'll know that that agent is not as astute as you are. That's the whole point here. You will always know more than the next person. So this is a good chart. We send this out to people sometimes when we're trying to convert them from F to G, when they don't believe us that there's only one difference, especially when the price is over $100 a month. So what else do you need when you have a Medicare supplement plan, when you go with original Medicare and a Medicare supplement plan? And I just want to kind of tap over here real quick. For people that have Medicare, original Medicare, and a Medicare supplement plan, and they go with a plan G, for example, there's nothing that could happen to them medically from head to toe or fingertip to fingertip, nothing on a medical scale that they would have to pay out of pocket except for that $183 deductible. If they went with the plan N, everything would be covered. The plan G, the $183 deductible. The plan F, everything would be covered. The plan G, the $183 deductible. The plan N, the $183 deductible, the risk of excess charges, and $20 office payment copays. Look at the bottom left. Plan N covers Part B coinsurance at 100%, except for $20 office payment copays and emergency room copays. It's sometimes a much better economic value for the consumer. So if they go with original Medicare, they're going to have to pick up a prescription drug plan. If they're not on any drugs and they don't take one, down the road, if they ever pick one up, they're going to be penalized 1% a month for every month they didn't have it. Secondly, if they didn't pick up a prescription drug plan, and in the middle of the year, they get prescribed something extremely expensive, they can't get one. They're stuck paying full price. And if they get prescribed that in February, well, guess what? That's 11 months of full price. And some of those meds are $300 or $400 or $500. So even if the client's not on any prescription drugs, you want to be as adamant as possible. You need to pick up a prescription drug plan. Even if it's the cheapest one, you need to have it. If you don't have it, it can cause a lot of problems for you down the road. They must have Medicare Part A or Part B, either or. They must have selected the first time of eligibility or face the late enrollment penalty. Some plans have deductibles, some do not. This particular office loves to offer to clients plans without deductibles. That's kind of our theme over here. For 2019, the standard Part B deductible is $415, $3,820 in initial coverage stage, $5,100 in out-of-state pocket threshold, and once they get into catastrophic, $3.40 up to $8.50. I am going to do another module. I'm going to do it Monday morning, and it's going to be how Medicare Part D prescription drug works in the different stages. That way you can explain it to people. Premiums range from about $15 a month to over $100 a month. You must adhere to drug formularies. They are overseen by CMS, and the commission is exactly the same no matter which PDP you sell. So a lot of people believe if I sell the $100 a month PDP, I'm going to get a bigger commission than I sell at the 15, and the answer is absolutely not. It is identical, the same. Okay. Now, moving on to Part C a little bit. What I wanted to do, I put these slides in the wrong order, but I wanted to talk about who a typical Medicare Advantage buyer is. It's a completely different animal, whole different person altogether. And these are generally the guidelines. It's not the rule. It's only the guidelines. And typically, someone who cannot afford a Medicare supplement in a Part D. That's usually the bell ringer. Somebody who can't handle $200 a month, or that $200 a month is going to be the stress of the world on them, and they're not sure they're going to make it for the next several years. So you got to listen in on that one. If you start to hear the pushback on the money and the premiums, and they can't afford it, you know right then and there you don't have a Medicare supplement buyer. You got a Medicare Advantage buyer. Somebody who uses the VA is a great candidate for Medicare Advantage. Someone who has Medicaid, that's their only option, is a Medicare Advantage. You legally cannot sell them a Medicare supplement plan. Even if they wanted one, you can't sell it. Someone who cannot be underwritten for a Medicare supplement. You're going into the annual election period, and a lot of people are going to come to you that are going to want to get out of their Medicare Advantage plan, and you're going to come to realize that they can't because of their health. So for somebody that can't be underwritten, Medicare Advantage is going to be their only option. Somebody who can afford a Medicare supplement plan, but the premium cost, the Part D, the ancillary products generally become greater than the MAPD maximum out of pocket. Now, what do I mean by that? Well, let's take Miami, for example. I always use Miami as an example. In Miami, a Medicare supplement premium is about $300 a month. So when you add in the Part D, when you add in the dental, vision, and hearing, you're at nearly $4,000 to $5,000 a year for premiums. And if you look at the Medicare Advantage plans in Miami, most of them, a good lion's share of them, have a maximum out of pocket of $3,000. So it's really hard for a client to justify giving insurance companies $5,000 worth of money when they could just go into one of these zero premium plans and only be at risk for $3,000 for the year, especially if they're not a heavy utilizer. So typically in the more expensive markets, a lot of clients will lean towards a Medicare Advantage simply for economic reasons. And they have two kinds of Medicare Advantage plans. I'm going to get into those in just a second, but that's a big one as well. Again, if you notice the theme here, it all draws the line to money. Money is what decides where these people go. It's all about money. Someone who's not a heavy utilizer or hardly at all, but recognizes they need to do something. We speak with a lot of people who tell us that they don't go to doctors. You know, why should they pay for coverage when they're not going to use it? Well, that's, the big myth of insurance. You don't buy insurance because you're going to use it. You buy insurance because you hope one day if anything happens, it's there to be used. So definitely a good candidate for Medicare Advantage if somebody is just adamant about that. And then finally, somebody who doesn't want to pay for health care. If you ever wanted to start a fight at a party, you don't bring up religion or politics anymore. You bring up health care. So healthcare is probably the number one most controversial topic that we've had probably for the last 5 to 8 years. So there are some people that are just adamant about paying for healthcare, just angry and peed at the world. Perfect example for somebody that would be a typical Medicare Advantage buyer. And then finally, anybody on Medicare disability. It is cost prohibited in most states for that person to buy a Medicare supplement plan. They're $500, $600, $700. In some states like Ohio, it's not even offered. In other states like Maryland, the Plan A is the only available option. So more often than not, 95% of the time, a Medicare disability person is being forced into the Medicare Advantage market. Okay. So really quick, what is Medicare Part C? Medicare Part C, you must be entitled to Medicare A and pay for Part B. You need to have both. You are turning over your Medicare benefits to a private insurance company. They must offer benefits equal to or greater than Medicare and must include a stop loss, which is maximum annual amount of spending, or a cap on your annual out-of-pocket costs, typically between $3,000 and $10,000. There are multiple different plans available: HMO, HMO POS, PFFS, PPOs. They must have, most of them have Part D benefits, okay, MAPD. Not all of them do, but most of them do. Some of them charge a premium, others have a zero premium. Special needs plans are designed specifically for those on Medicare and Medicaid. They're called D-SNP, dual special needs plans, Medi-Medi, D-SNP. There are SNPs for those with certain chronic conditions such as diabetes, COPD, heart disease, only in certain markets, and they're called C-SNPs, chronic special needs plans, C-SNPs. Enrollment periods exist with Medicare Advantage. We are just about to get into the annual election period, so everybody can get one. They may include additional benefits such as dental, vision, hearing, gym membership, silver sneakers. Believe it or not, it makes me laugh when people bring up silver sneakers, and I joke, and when clients ask about it. On a national scale, less than 16% of the people that have access to silver sneakers actually utilize it. Less than 16%. That's 1 out of 7. So the next time, count up the seven people that ask you about silver sneakers, and laugh in the back of your mind that only one of them will actually use it. In fact, some people won't pick up a plan unless it has silver sneakers, and they turn out to be the ones that don't use it. Transportation, meals, and over-the-counter allowances. And in some markets, the plans will give back some or all of the Part B premium. What does that mean? That means instead of paying the $134 to Medicare, if you go into Medicare Advantage plan ABC, ABC will reimburse that client $80 or $90 back to their Medicare. So again, money. It all draws down to money. You have somebody on the fence, their income is not very high, they're not even sure how they're going to pay for Medicare. They don't qualify for extra help. If you got a Part B give back plan, that means the world to them, because now they don't have to pay a monthly premium or a very little one to get their medical and their prescription drug coverage. Okay? Really quick, because I want to try to keep this under 30 minutes. There are 2 different types of HMOs. One's called a regular HMO. The other one's called an HMO POSOA. Real quick, HMO, you need a PCP. There are referrals to see specialists. You can only use plan doctors. They typically offer the lowest copays and cost sharing, so that's the trade-off, managed care. And then generally they have the richest extra benefits: dental, vision, hearing, transportation, over-the-counter, and Part B give back. So where your trade-off is you got to use their doctors. You got to go to their doctors when they allow you to go to their doctors, but in exchange, you're paying much less for your care. Open access is a little bit different. You don't require a PCP referral. You can go to any doctor in the network. And typically, those 2 insurance companies that you see there are generally the big front runners for point of sale and open access based plans. PPO is the other one, preferred provider organization, no PCP required, no referrals to see specialists. Can use plan doctors at a lower cost or use any doctor at a higher cost. High copays and cost sharing versus HMO. Not as rich with the extra benefits. They may have a plan premium, depends on the county that they're in. And a lot of them I'm noticing have an added network deductible, usually between $500 and $1,000. Let's talk about this real quick. PPO says you can go to any doctor you want, correct? Yes. However, it doesn't mean that the doctor that you're going to go to that's out of the network will service and bill. In other words, it doesn't mean you're going to go to that out-of-network doctor, give them your out-of-network insurance card. They're going to take the card, they're going to go perform a service on you, and then they're going to go and bill the insurance company to be paid. It doesn't necessarily mean that. Some doctors will, some doctors won't. So it's very important that if you're recommending a PPO to your customer, you always want to try to find the one that has all their doctors in the network, even though they can go anywhere. But if you come to the end of the road and there's only 1 or 2 doctors that are not in the network, you just got to make it very clear to these people that they can see that doctor all day long, but it doesn't necessarily mean the doctor's going to do all the financial billing on their behalf. They may be forced to pay the bill and submit the claim. So very, very, very important. Number 1 complaint in Medicare Advantage is doctors not taking the plans. I'm going to just pause for 5 seconds about PFFS. I'm not going to talk about it because it doesn't come up often, but you can pause this video and read. So I'm going to just count to 5 in my head. Okay, and then here's just a quick little chart I found on the internet. It kind of gives you a good side-by-side. I certainly wouldn't send this to a customer. This is just for you. It kind of gives you a kind of an overview of the different areas, Medicare supplement insurance plans versus Medicare Advantage, and it's just basically everything that I went over. Referrals, network, enrolling, and things of that nature. And then finally, what are the next steps? If you are part of our network, feel free to reach out for any additional questions or training you feel that you want. I will happily do any one of these on any topic that we can legally do. That's the one area that we're going to really abide by, is the copyright infringement area and the revealing of company secrets and things of that nature. Whatever we can legally do, because these are all public viewing, we will happily do. If you're not in our network, perhaps we should entertain a call to see if we're a good fit for you. We are not a one-size-fits-all. However, we do provide very detailed one-on-one training and support, and the agents that we work with will attest to that. If there are any carriers that you've seen in this training, which I didn't reference any, and you'd like to know more about, let us know. This is our email. You can call or text me at that phone number, and that is how I spell my name. So there you go, exactly 30 minutes to the T. Thank you, and have a wonderful, wonderful, wonderful day.